Hi, this is Rachel Hine and Heather Levitas, Duke Plastic Surgery residents. This is a lecture series designed to aid in preparation for our yearly in-service examination. Our goal is to take you through high-yield topics with experts in their respective fields in order to maximize your knowledge and potential scores.
We're here today with our subject matter expert, Dr. Mark Constantian. Dr. Constantian is a nationally renowned cosmetic surgeon and past president of the New England Society of Plastic and Reconstructive Surgeons, the Northeastern Society of Plastic Surgeons, and the Rhinoplasty Society. He's the author of multiple publications, including his textbook, Rhinoplasty, Craft and Magic, and is also an associate professor of plastic surgery at the University of Wisconsin Medical Center. Thank you for being here with us today.
Welcome, I'm delighted.
Today's cast will focus on the all-important topic of patient selection with a specific focus on body dysmorphic disorder. As we know, not every patient who seeks a consultation with a plastic surgeon is physically or emotionally suited to undergo an operation that can result in a significant change in his or her appearance. Dr. Constantian has written extensively on this issue, and we look forward to his insights.
According to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, the following criteria define the diagnosis of body dysmorphic disorder, BDD. A preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to others. At some point during the course of the disorder, the individual has performed repetitive behaviors. Examples are mirror checking, excessive grooming, skin picking, reassurance seeking, or mental acts, including comparing his or her appearance with that of others in response to the appearance concerns that the individual has. The preoccupation causes clinically significant distress and impairment in daily function, and an eating disorder may be seen with body dysmorphia, but is not pivotal to its diagnosis.
So before we get started in talking about patient selection for body dysmorphic disorder, I wanted to ask you a little bit about your first encounter with body dysmorphic disorder and how you became interested in this topic.
I backed into it innocently, but I was distressed by what happened. I had operated probably in the mid-'80s on 3 patients in whom I thought I'd gotten great results, and they were miserable after. Distraught, miserable. And I had no idea why. One was a university professor who gave up her job teaching and lived like a recluse in a city where nobody would recognize her. The next was a physician's wife who became angry and abusive and hostile and wanted more surgery for real but microscopic imperfections that were devastating to her. And the third was a man who owned an auto body shop. And the fascinating thing for me was that he had this very sophisticated idea about aesthetics. He talked about planes and light reflexes, and I thought, this guy really gets it. This is because he does auto body work, so he understands all of this. I thought he would be very easy. Despite his limited education, he spoke like someone very educated in facial aesthetics. So I operated on him, and he was so distraught that he tried to amputate his nose with a razor when I was out of town. Didn't really do any damage except lacerate the skin. But all these people had very good results. What I thought was the best I could have produced in this situation. I'd be happy presenting any of them at meetings. And yet they were very unhappy. And when I tried to reassure them, when I tried to talk to them, when I tried to show them their photographs and explain that the deformities they saw were not there, they absolutely didn't believe me. And all of them wanted more surgery. And I never operated again on any of them. The second woman I had told, I can take care of that little bump in your inner wall. And at a year, when it came to a year, I said, okay, we're finished. And she said, what do you mean? You said you could fix this. I said, I can, but I won't. Because the first surgery disequilibrated you so much, and I don't really understand why, which is true at that time. And I don't know what I did, but you were so upset, it took you so many months to get back to equilibrium that I don't want to do it again. And I don't think you should have more surgery. So she left enough. And I thought, I'm going to find out what I did to these people, because it made no sense to me that the problems weren't imaginary. The problems were imaginary, and that even though they saw them, I couldn't talk them out of the ideas they held. They were absolutely positive that these things existed, and they blamed me, and they wanted more surgery as a result. They thought that the feeling they had was that somehow I'd just been totally incompetent. And it wasn't a problem of healing. It was a problem of the surgeon really being no good. So I went to the literature and I read the version of the criteria that existed in the mid-'80s, which was pretty similar, although instead of saying it was a perceived problem, they used to say an imaginary deformity. So this new definition is a little kind to the patients. But the missing piece for plastic surgeons, there were really two missing pieces for plastic surgeons. One was we saw different patients than the mental health professionals were talking about. They saw patients in whom the diagnosis had been made usually, and were coming in for surgery, coming in for treatment once a week. And we saw patients who were coming in for surgery, so their criteria didn't help us. Secondly, lost my train of thought.
That's okay. It's fine. Happens all the time.
You were talking about the two things that...
Oh, the other thing that was missing was the etiology. That really bugged me. Why should this happen to some people? And still, the etiology is unexplained in the mental health literature. The best experts at this point still say that this problem happens just out of the blue to some people in adolescence or the early teen years, and then all the things you talked about happen and their lives fall apart and their self-esteem goes down, and they get depressed and they may develop eating disorders or depression or obsessive compulsive disorder or social anxiety disorder. All this stuff has been studied. And then the worst patients commit suicide, and we really don't know why. It may be a neurotransmitter we haven't identified, even though we've looked, or it may be a genetic abnormality that we can't find. And when we look at MRIs, the thalamus and the limbic system all light up, and they say, well, this is the worry circuit of the brain. Isn't that interesting? All that, to me, was not helpful, and it's still not helpful. And so I began to think, I better try to figure out why this is happening. So my connection to it came on very innocently, and then as time went on, I began to get clues.
So you kind of started talking about the definition versus your experience. So in your experience, what kind of associations did you make with these patients? You talked about how the mental health professional now associates it with more of an anxiety and obsessive compulsive disorder rather than what the DSM-3 criteria had originally defined it to be. Can you talk more about the associations that you find with body dysmorphic disorder?
The things that were prominent to me were that the patients they lived at the extremes. They were either the sort of disempowered patient who you ask, what would you like? Well, I don't know, what do you think? These are always clues to plastic surgeons. If they're a bad patient who can't describe what he or she wants. Well, what's wrong with your mouth? Well, I'm not sure. I think maybe it's this area, or I think maybe it's there. I'm not sure. And this is the person who forgets all his or her appointments and doesn't show up for lab work and needs to be called to come into the office for regular checkups. Or you get the opposite extreme, the grandiose patient who expects a discount, wants to be seen on weekends because they're so important, doesn't have time for the usual lab work, you need to make all kinds of exceptions for them. So they don't act like functional adults. They often have either hidden or very obvious self-esteem issues. They misinterpret what I say, or they metabolize it. They distort what I say, and there's some meaning that I never had, and that most people wouldn't conclude from what I said. For example, I'll say, you got distressed after the last appointment, and they'll say, you're telling me I'm a bad patient, which is not what I said. But they can make it into an insult when it's an act of compassion on my part to try to figure out why they were upset and what I can do differently. And they don't take care of themselves after surgery, and they don't live in moderation. So those were all clues of the fact that these people didn't act like functional adults. And the conversations that I had with them were not the conversations that you have with functional adults. It wasn't, this is imperfect, what can you do about it? it was, I trusted you and you betrayed me. I trusted you and you experimented on me. I was your guinea pig. These aren't the things you say to your surgeon or to anybody else you're going to have a decent relationship with. So even though they may have just trusted me to operate on their faces, afterwards, all of a sudden, they're accusatory and angry, and like I deceived them, and was just deliberately untrustworthy. So all of that began to disturb me, and I began to put it together. I realized that a few years ago that I had seen a group of patients that all seemed very similar. And when I put their stories together, pulled the cases, they were similar. I couldn't put my finger on it when I thought about them, but I pulled the charts and started assembling data. And it turned out that these all had multiple rhinoplasty. They also all had multiple other cosmetic surgeries. They were all very depressed or demanding of the staff, requiring unusual amounts of time. And the great majority, something like 80%, had recounted stories of childhood abuse or neglect. Just in my discussions with them as a surgeon came out. So I thought, okay, there's got to be something to this. And the kind of behavior that I was observing was what you observe in people who've been abused or neglected. They don't act like there's functional adults. And I thought, well, maybe the things that we see as body dysmorphic disorder didn't start like out of the blue for some incredible reason, but that they're all connected to what happened previously. Maybe BDD is a kind of post-traumatic stress disorder. So, because it has a lot of the characteristics of PTSD. It has all the brain characteristics, the identical brain characteristics on functional MRI, and a lot of the behaviors and the addictions and the dysregulated behavior and the living on the extremes and the suicide attempts all fit with the PTSD diagnosis. So I began to read about more of the childhood trauma literature and the BDD literature and the body image literature and the PTSD literature. And all of these groups had their own little prescribed areas of information, but they didn't cross-communicate at all. And so as I read all of this, the pieces began to fall into place of a disorder that began not out of the blue, but began as a result of childhood trauma, the self-esteem issues, and the family disruption, and the depression, and the disempowerment, and the dysregulated behavior, and the childlike behavior, didn't all come from the sudden obsession with a body part, but were intrinsic characteristics of these patients because they'd never grown up right. And then they made the connection to some appearance thing. And then I came across a paper by a psychiatrist named Bernice Andrews, who's retired now. She used to be in London. And she had studied a lot of patients looking for the kind of shame that follows childhood trauma, because the ubiquitous end product of any kind of childhood abuse or neglect is a feeling of shame. There's something wrong with me. And my parents got divorced because of me. I used to get beaten because of me. I deserved what I got. People, they criticized me a lot, but it was because I really was not a very good child. My parents drank because of me or whatever. That somehow I deserved what I got. And she looked at the three different kinds of behavior of shame that they describe in mental health literature. Characterological behavior, what kind of person I am inside. There were three others mentioned last night.
Body shame was one. Right.
No, body shame. Oh, characterological shame. Okay, characterological shame, behavioral shame, the way I act, or body shame. Those were the three types, and they all came out of childhood trauma. But the one that was the most common was body shame. And I thought, okay, there's the missing connection. You start off with childhood trauma, you develop body shame. It's different from body dissatisfaction, which we'd rather see as plastic surgery patients. And you then decide that plastic surgery is the option, the way to fix it. And so the reason these patients never get better and are so difficult is because the surgery nothing, the complaint and the surgery, therefore, have nothing to do with the deformity. They have to do with a sense of self-esteem and a desire to get self-esteem, which of course you can't get from surgery.
How would you typically handle your initial patient consultation, knowing all of these things, keeping all of this in the back of your head?
Yeah, I guess you talked a little bit about patient dissatisfaction versus, patient shaming or body shaming. When you see a patient, how do you initially differentiate this? We are taught red flags based on our DSM criteria, but when you see these patients, is there anything you initially look for?
It's difficult. You can't do it quickly. You really have to get to know these patients. The basic criteria I like to use before accepting a patient for surgery is that I have to be able to see the deformity, and I have to feel that I personally can fix it. But a lot of patients will, as they describe the problem, or as they describe the previous surgeries, shame comes up, embarrassment comes up, lack of self-esteem comes up, and you realize that that's really the overarching feeling you get. This patient is not motivated by a physical problem, and they know they're fine people, and they've got a good sense of themselves, but this particular body feature or facial feature is imperfect, and they'd like to fix it. But that this facial feature is another manifestation of how rotten they are. That's the problem patient, because the issue is not the deformity, and therefore whatever you do surgically doesn't make you happy. And then the problem that happens is when people have been wounded as children, and something triggers a childhood memory of feeling shamed again, they react like they did as children. These were the compensatory things they did as children to get their parents to back away or to survive in that crazy environment. But now those things aren't appropriate as adults anymore, that kind of behavior. But they turn it on the surgeon, so the kind of irrational things they're saying, you betrayed me, whatever. This is the kind of thing you say, to your mother when she says, I'll be home at 5 o'clock to fix your dinner, and she shows up at midnight drunk. You didn't take care of me, you didn't betray me, I trusted you, and look what you did. That's what you say to a parent who's abusive. It's not what you say to your surgeon who's trying to fix you. So all of the verbiage begins to get screwed up, and you realize you're not talking to somebody who's talking to you like a normal patient. So the part of the clue is to try to get a sense of the motivation of the prior surgery, of the current surgery, and to feel that I can personally fix it, and that I have a patient who understands that perfection is not the surgical goal. Perfection is the best I can do. The problem is that these patients come in compensated and motivated to talk the surgeon into things. That's why the screens for body dysmorphic disorder, for me, have been used since I tried one years ago that was being developed by a very good psychiatrist who's an expert in this. And the questions are too transparent. How many hours a day do you think about your nose? Nobody's going to let down. They think obsess all day long because they're sitting in the waiting room waiting to talk the surgeon into operating them. So they're going to hide it. And it only comes out afterwards when the result is good, the patient's unhappy, and the behavior becomes angry, abusive, hostile, dysregulated, and so on. So I don't always get it right. The other problem is that you can't screen for trauma and use it as a method of screening for patients. I've done a study on more than 200 now patients looking for childhood trauma. And in my patient population, which is basically an elective aesthetic surgery practice now, this is not a disadvantaged population. The overall prevalence of childhood abuse or neglect of some kind is over 80%. And in patients who come for reconstructive surgery, skin cancers, it's 70%, which is a little high still, but not totally out of whack with what you find in general medical populations at the same cultural level and socioeconomic level. But in patients who've had multiple prior cosmetic surgeries, it's over 90%. What's interesting is that the prevalence of divorce parents is low, it's 20%, so they don't even come from broken families. But the areas where my patients have been abused or neglected the most is emotional abuse. That's way up there. It's more than 50%. That's much different than the general medical patients, where about 20 or 25%. Drug or alcohol abuse in the family, or a parent who's mentally ill, three things where prevalence in plastic surgery patients is much, much higher than it is in general medical patients. The problem is that that number can explain some patient behavior. It doesn't explain all patient behavior because there's this factor of human resilience, which I also think the mental health will have wrong. But there's this quality of being able to survive. So I can't predict in knowing my patients what their trauma score is, because the nicest, most wonderful, most grateful, most easy patients can have high trauma scores. They've just been able to triumph over them. They somehow have this antidote to trauma, which is resilience. And most of them can relate it to someone outside the nuclear family where most of the abuse happens. The caregivers, outside the caregiver group, to some coach or some minister or some teacher or some relative or grandmother and aunt, someone who believed in them and who built up their sense of self and allowed them to dilute what went out of the family.
So do you feel like body dysmorphic disorder is more related to childhood trauma or lack of resiliency, or both?
I think both. I think childhood trauma in some people creates a feeling of worthlessness that translates to body shame, that gets attached to a body part. Not everybody who is abused or neglected seeks plastic surgery, but many need. The prevalence of childhood abuse and neglect and morbid obesity is very high, it's over 80%. And that's something, again, plastic surgeons don't know anything about. All this stuff is in the mental health literature. It's not in our literature. And that's really the problem, because we do all this body contour surgery, and we don't know anything about these patients. I'll see patients who've had body contour surgery that come to me, prenasal surgery, and they say, I used to weigh 350 pounds. And I say, usually people that weigh that much have had rough childhoods. And they start pouring out the story of their childhoods. This is in the first interview. And then they look and they say, you're the first person that ever asked me that. Now they've already been to other plastic surgeons because they had their body contour surgery. They've been to the bariatric surgery and gotten a psychological screen, whatever it's supposed to be. Nobody's talked to them about their childhoods, which is such a huge element in the history of morbid obesity. We're missing enormous pieces of this. I gave a lecture at the association a few years ago when I was just getting into this. And I said, we don't know what kinds of childhood predate the patients who are the most grateful, or the most difficult, or require the most pain medication, or have the most complications. We don't know why some patients, two patients with the same hand injury, one will get better quickly, and the other one gets a chronic regional pain syndrome. I bet that's related to childhood trauma. We don't know where chronic pain comes from, and the histories in a lot of these patients, and then we operate on them. When I was a general surgery resident, all I was taught to ask about was, do you smoke or drink? You have high blood pressure, and these are the things I screened for. And still, that's all generally people look for in the medical traps. There are other traps.
I had just been reading your KRS editorial that you wrote in response to the DSM-5 when it first came out, on how potentially plastic surgeons and psychiatrists should be working in conjunction to come up with these criteria. I just wonder if, since that editorial, your opinion has changed, or how it's evolved, if at all.
I actually believe it more than I did, for a couple of reasons. The first is that after Dr. Edgerton died just recently, they're going to devote a special issue of the Journal of Craniofacial Surgery to him, for which I wrote the paper, because he was a big influence on me since I was at the University of Virginia at the same time he was, and he was very interested in body image. He had a psychiatrist in the department. And when I went back and read some of his earlier papers in preparation for the book I just wrote, Childhood Trauma and Body Image, he first wrote about the patient with what he called minimal deformity in 1964 or 65. Now the DSM-5, DSM-3R, which is the first time BDD was described, didn't come out until 1987. So he predated it by more than 2 decades, and he described these patients exactly the way we described them today. So plastic surgeons deal with body image all the time. And we have a lot to offer because we see these patients in a whole course of treatment from the beginning through the surgery and the complications and the recovery, whereas the mental health professionals are getting little weekly or every other week snapshots. So we see them react to their environments and react to stress, and then we have to add something. The other piece is that the mental health professionals don't recognize at all for their part what plastic surgery has to offer. If you look at the diagnosis, the criteria you just read for compensatory behavior, they never mention plastic surgery, which is the way most surgeons and most physicians, dermatologists, other people who see patients with body dysmorphic disorder first encounter these patients. They're coming in looking for treatment or looking for cosmetic procedures. So we need the diagnosis should be made together, because the first criterion of a perceived deformity, who determines whether something is perceived or not? Is the patient? Is the family practitioner? Is it the psychiatrist? The fact that something is subtle doesn't mean it isn't there. I see patients who come in who've had nasal surgery and they've got airway obstruction, and prior doctors have been able to figure it out, and I examine them and treat them. That's not body dysmorphic disorder. And there are a lot of patients like that. And so the interface between what's cosmetic and what's reconstructive is very close, and therefore what we excuse as behavior is depends on our beliefs and biases. The same reaction that you would tolerate in someone who's just had a cancer diagnosis or lost a body part from cancer or trauma, you would not tolerate from someone who's had a cosmetic procedure, only because somehow the medical thing, the reconstructive thing, the cancer diagnosis is like more legitimate as a reason to react that way. So we can't judge every aspect of the mental health, and they can't judge really even the significance of the deformity without our input. So really that diagnosis should be too special a diagnosis. Right now there are a lot of people going around with diagnoses of body dysmorphic disorder who don't deserve it.
And that was another question I had, observable versus slight differences. The definition now talks about that being a warning sign. That seems so subjective to me, and you kind of mentioned that just a second ago when you were talking. How are you able to tell something that seems so slight or may not be observable? Is it expertise? Is it more just
as a screening
the patient's mannerisms? Yeah, as a screening mechanism.
I listen to the language. That's probably the easiest thing. Patients come in and if they say, my nose is a little crooked, or I've got this little bump and it's always bothered me, what would it take to do something about that? That's one thing. Now someone comes in and says, I've got this disgusting bump here. Really, they use disaster language. This hideous shape, and I can't take it anymore. And the disaster language is another sign of immature behavior. Everybody's got a small kid, 3-year-old, that falls down and scrapes his knee. They start crying because they think that pain is going to last for the rest of their lives. And what I always used to say to my kids is, wait, it's going to go away. And magically it does in about 30 seconds. But these people have never grown up, so they see a postoperative swelling at 6 days, and they think, this is it, it's going to be like this forever. And the next day they're calling, and the next day they're calling, because they have no ability to regulate their emotions, and they have no ability to look like an adult would at something that's obvious. What kind of surgery would you expect to be healed in 6 or 7 days? The patients are on the phone repeatedly, distraught because of something that is kind of obvious if you're a grown-up. Well, I mean, that brings up another thing. All surgeons have their histories too. What our backgrounds are determine the patients we like, the kind of physicians we become, the kind of practices we have, the kind of the patients the kind of subspecialty within plastic surgery we're willing to do. And so we all have patients that we can tolerate and not tolerate, and that all is related to our own histories. If you're going to do the practice I've got, you've got to have a high threshold for being distressed. And my staff does too. I tell them this is like having an oncology practice. Half the patients are really wound up and got to be willing to give a lot of TLC. Dr. Edrick used to call them hot potatoes.
Hot potato. Well, perhaps on our next in-service exam will be a question looking more introspectively at what sorts of neuroses plastic surgeons have, not just our patients.
So I think we have a couple of in-service questions that probably
we've answered.
We've answered and probably don't go along with the definitions that you have given us, which seem more
well-rounded,
more aligned.
Yeah.
Give me the questions. Let's talk about
Okay.
Oh, good. Okay. So this is a question from the exam we took this past March. So this is a recent question. A 20-year-old woman comes to the office with her parents because of her significant concern with the appearance of a scar on her forehead of 1 year's duration. Physical examination shows a well-healed scar that blends in nicely with the surrounding skin and is difficult to see at conversation distance. The patient's parents do not see the need for any intervention since they also find the scar difficult to see. Which of the following must be present to confirm a diagnosis of body dysmorphic disorder in this patient? The first answer choice is history of treatment for an eating disorder. The next answer choice is occasional social anxiety, preoccupation with obvious flaws in her appearance, prior rhinoplasty, or repetitive behavior related to her appearance concerns.
Well, it would be the last one. I see patients like that. A 20-year-old who comes in with her parents, that would bother me to begin with, because you don't need that much help to discuss a scar. The parents are sometimes they're overbearing, they're too protective, they're boundaryless. So the patient has never developed enough autonomy to come in and talk to the doctor, maybe with one parent or maybe by herself. So that I always wonder about that when you're gonna army a family to come in to discuss a small scar. But the circumstances, I've seen circumstances where it will bother a patient. In fact, I saw a woman recently. She'd been at some fraternity party, and one of the ceiling tiles fell and struck her and lacerated her forehead. And she's mad about that because it never should have happened. And so now she's got this scar and she hates it. And all she does is remember the idiots at the fraternity house and how the insurance company wouldn't cover it. And there's a lot of anger bound up in that. So I have to sort of recognize that she's got a legitimate reason to be annoyed and to have bad associations with this. And so I'll say, if the scar is transverse and I don't think it's possible to get it better, I'll say, I don't think there's anything you can do about it. And I'm sorry, I really recognize you're ticked off, but this is really a good result, and I'm glad it wasn't worse. And some patients will be happy and go away like that. If I think I can revise it and make it a little better, I'll say, I can just try to do something. I can put W-plasty in it or do some kind of revision, but you're still going to have a different scar. It might blend in a little bit better, but it's not going to disappear. So maybe it'll be 25 or 50% better. And some patients will say to me, anything you do, even if it's no better, I'll feel like, okay, at least I tried. And now I'll move on. And other patients will say, unless you can tell me it's going to be 90% better, I don't want an operation. That's crazy. So those are both correct answers for different people. Now, so I'm feeling my way through the conversation as I do that. If the parents tell me, she won't go to school and she won't have a job because of this, that's different when if it's a minor scar. I did see a young man just recently. He's got airway obstruction and he thinks that his nose isn't right and he's dropped out of college because of it. And the deformity is negligible. And I said to him, you really don't need surgery, you need trauma work. Of course he'll never get it. But that's a huge overreaction for something that, what would it take to make someone drop out of college? A lot.
So we have one more question, and I think the answer is going to be a little bit different because we have new DSM criteria. So we'll go ahead and ask it. Do you want to do it?
Sure. So this was a question from 2014. A 22-year-old woman comes to the office for consultation because she is dissatisfied with the appearance of her nose. History includes 2 cosmetic procedures of the nose. During the consultation, she also expresses dissatisfaction with the appearance of her eyelids, chin, lower abdomen and flanks, and breast size. In this patient with body dysmorphic disorder, which of the following additional findings is most likely? Anorexia, anxiety disorder, depression, hypochondriasis, or substance abuse?
Which is the most likely
Yes.
to accompany? Actually, the literature shows several of them. They've taken eating disorders out. But if you look at the things that follow trauma and body dysmorphic disorder, you get a lot of them when patients are depressed. A lot of them have social anxiety. What were the others?
Hypochondriasis and substance abuse.
Right. Substance abuse is common too, either pills or drugs or alcohol. Hypochondriasis, it's hard to know. It's the patient who's completely fixated on her appearance. But you know, the fact that a patient has had multiple cosmetic surgeries doesn't mean they've got body dysmorphic disorder either. I mean, that's kind of, you do see those patients. There are people who are, they may have had some childhood trauma in the sense that they learned in their childhood that the way they stayed out of trouble was to be perfect. And they still won't have to be perfect. And that's the way their lives run. And so any little thing, they've got the money to do it, and they live in a culture, maybe they're living in Miami or in Los Angeles. You're not going to see it in Oklahoma City. I'm not going to see it in New Hampshire. I mean, this would be much more uncommon culturally. But in your environment, if someone came in and they were in the movie business and they'd had these surgeries, it wouldn't surprise me. So the fact that somebody's had a lot of surgery, and they put a lot of plastic surgeons' kids through school, I guess. But you know, if they had the surgery and they're happy, and they coming in for another rhinoplasty, and there's a real problem because the surgery is so hard and so many patients don't get great results, I wouldn't hold that against them. That's some of my patients like that. But they still have to fit the other criteria. They have to be grown-ups. I have to feel like I can work with them. I have to feel like they understand what I can actually do.
So they answered that depression was most likely. However, in the explanation, they do mention that substance abuse is also common, as is anxiety disorder.
Yeah,
so
social anxiety disorder. There's lots of papers about the coexistence of that. So that'd be a tough.
That was probably a
even
tough question.
Even if you know the literature, it's a tough question.
Is there anything else you think we didn't cover that would be important to talk about?
Only that both these questions are still based on the manifestations. We still describe body dysmorphic disorder like we're describing pneumonia in 1870 or 1840. We know the fever, we know the cough, we know the prognosis is poor, it's severe, but we don't have any idea where it comes from. And this is the problem. We're describing all the manifestations of the disorder without understanding why all these other things coexist with it and what the root of the problem is. And this is why cognitive behavior therapy has a mediocre track record, but that's the standard treatment for BDD. You give antidepressants and you do cognitive behavior therapy, which is where you sit down with someone and they give you projects. You think your nose looks really awful. Well, I want you to go to a shopping mall and write down the number of people that stare at your nose, and then come back and we'll talk about it next week. And the person comes back and says, well, then it can't. Your nose really can't be that bad, right? So now, write down all the things that you think other people think of you, or the things that how it would affect your life and people who like your nose. And you go through these exercises. The problem with all of that is that's all cortical function. And trauma is not in the cortex. Trauma is in the midbrain. We're born, only our spinal cords and brain stems are working at birth. And little by little, the midbrain comes online. And you begin to learn what's dangerous, what's safe. You know, if you cry and somebody beats you, you've got a very different view of the world than if you cry and somebody cuddles you. So this is how all this gets tuned as infants and children. And it's only when children start getting to be 3, 4, 5 years old that their real cortical function really comes on. And it's only when they get to like first grade that they can begin to plan projects. You have a 3-year-old child, you try to get dressed, you put on one sock, then you try to put on the second sock, and she pulls off the first sock because she thinks it's a game. She doesn't have any idea you're trying to get dressed with a purpose to go someplace. So this is the way the brain develops. And if the trauma occurs with an undeveloped cortex, which it so often does because the family is dysfunctional from birth, then all the damage is at that level. And that's what trauma work does, it treats that level. You can't talk somebody out of body dysmorphic disorder by explaining to them that what they see isn't really what they see, because that's all cortical, and that's not where the origin of the problem is. That's why our success rate in treating PDD is so mediocre.
Well, thank you so much, Dr. Constantian. We really enjoyed having you today. It was an honor.
Thank you so much. This
My
is great.
pleasure.
I think people are going to really enjoy listening to this.
Good. I didn't talk to you.
No, that is fabulous. Thank you.